Hello, I'm Dr. Sakshi. So today we'll be discussing about approach to a patient of hyponatremia. So what is hyponatremia? First of all, we should know the normal sodium level in our body. हमारी normal sodium level होती है 135 to 145. तो कभी भी sodium level अगर less than 135 हो जाए तो we call it as hyponatremia. अब now we need to know that what is the cause of hyponatremia, because accordingly we have to treat the patient depending on the cause of the low sodium levels. तो हाइपोनेट्रीमिया के लिए सबसे पहले हमें वी नीड टू हाइड्रेशन देखना होता है सबसे पहले पेशेंट का, वेदर व्हाट इज़ द हाइड्रेशन ऑफ द पेशेंट. पेशेंट इज़ डिहाइड्रेटेड, पेशेंट इज़ नॉर्मल, और पेशेंट इज़ इन हाइपरवॉल्यूमिक स्टेट. अगर तो पेशेंट डिहाइड्रेटेड है तो हमारी अप्रोच देन after that, once hydration has been checked, then we have to check with the sodium, urine sodium levels. So first of all we'll discuss about this hypovolemic hyponatremia. तो अगर if the patient is dehydrated, we call it as hypovolemic hyponatremia. If the hydration level is normal, we call as euvolemic hyponatremia. If the fluid level is increased in the body, then it is called as hypervolemic hyponatremia. So hypovolemic hyponatremia, in this we have to check for the urine sodium levels. So if the urine sodium level is greater than 20 milliclins or it is less than 20 milliclins. If it is greater than 20 milliclins, that means the cause of low sodium level is renal cause. And if it is less than 20 milliclins, that means the cause of this low sodium is some other cause of fluid loss, like gastric cause. So renal causes में क्या आता है? Renal causes में we can see that there can be this renal tubular acidosis, there can be mineralocorticoid deficiency, primary adrenal insufficiency जो होती है, that causes hypovolemic hyponatremia. हमेशा याद रखना, जो this primary adrenal insufficiency, which is called as mineralocorticoid deficiency, that causes hypovolemic hyponatremia. So, और अगर secondary this adrenal insufficiency होगी, like if there is some pituitary cause of this adrenal insufficiency, then it is called, it causes euvolemic hyponatremia. So always remember this, okay? Then there can be renal tubular acidosis, then the recovery phase of the acute tubular necrosis, that can cause hyponatremia. Then drugs causing hyponatremia. Then acutely the sodium can be lower in the body due to this post-operative patients, especially the premenopausal women. They are highly prone to develop hyponatremia. Then this irrigation that was done in urology for following TERP, then thiazide use, ecstasy use, then thiazide, that antihypertensive that we use. Then this gastroenterology, we use the for doing the gastric lavage, we use that liquid that patient has to drink, that can also cause hyponatremia. So we need to take the proper history in order to know the cause of the hyponatremia. So these are the renal causes of hyponatremia. Now the extra renal causes, if the sodium level is less than 20, that means the source of sodium loss is not renal, it is extra renal. The extra renal causes could be the gastric loss in the form of vomiting or this loose motions. Then there can be third space loss in pancreatitis, burns. So anything extrarenal that causing fluid deficit in the body, that can lead to hyponatremia. So this is the way we know the causes of the hypovolemic hyponatremia. So in this hypovolemic hyponatremia, this is differentiated from other hyponatremia, where the only gold standard is that we have to give fluids, and if the patient and the sodium improves dramatically, it improves very nicely. So that means this is the only gold standard that how we can differentiate it from euvolemic hyponatremia. Then there comes the euvolemic hyponatremia. Euvolemic hyponatremia, urinary sodium is also more than 20. It is usually greater than 30 milliequivalents. So euvolemic hyponatremia, the causes are, most importantly, is SIADH. Okay, so there are the types of also SIADH. Like first, erroneously the this ADH that is getting excreted from the, erratically it is being released from the pituitary gland. So this could be one of the cause of increased antidiuretic hormones. Second, that there is low thermoset. In some of the patients, the osmostat it is reset, that the threshold for release of the ADH is lower. So they don't behave normally even in low this the osmolality level is low in this patient, and the ADH is released at that level also. And third is that ADH, erroneously, it there is occur gain in the function of the receptor of the ADH on the renal tubule. This receptors are V1A receptor and V2 receptor. V1A receptors are present in the blood vessels, and V2 receptors are present in the renal tubules. So those get stimulated erratically because of the gain in function of the receptor. So this is called as nephrogenic diabetes insipidus. So this is the most common cause of euvolemic hyponatremia. Other causes of euvolemic hyponatremia is severe hypothyroidism. Third is the glucocorticoid deficiency. Okay, so in glucocorticoid deficiency, if you give the steroids from outside, they improve with steroids only. So that is the pituitary cause. Basically, that's the pituitary cause of this glucocorticoid deficiency. Then comes the hypervolemic hyponatremia. In hypervolemic hyponatremia also, we'll see that whether the sodium level are greater than 20 or it is less than 20. If it is a greater than 20, that means it's the renal cause of hyponatremia, acute on chronic renal failure. If it is less than 20 milliclins, that means the cause could be extrarenal in the form of there can be cardiac failure, there can be cirrhosis, or nephrotic syndrome. So these are the causes of hyponatremia that we know. So one important test that we can do which can help in detecting euvolemic hyponatremia is the uric acid level, SIDH. In SIDH, the uric acid level we have to check. If the uric acid level is there, in the SIDH, the uric acid level is always less than 4. Whereas in hypovolemic hyponatremia, the uric acid level is more than 4. So this is also one of the differentiating factor of differentiating between hypovolemic and euvolemic hyponatremia. Then the third thing is the beer potomonia. Beer potomonia is the condition that is seen in people, those who drink lot of beer. So because they are taking beer, so they don't eat anything. Because of this, the sodium level falls in them, and they are also malnourished. So the one of the serious side effect of this hyponatremia, treatment of hyponatremia, that is the ODS, is more commonly seen in these patients. So this is about the approach to a patient of hyponatremia. And then there is one more term which is called as chronic hyponatremia. Chronic hyponatremia means that the sodium level that falls slowly over a period of 48 hours. Basically, now what is the pathophysiology? Because if you know the pathophysiology, that what happens when the sodium level falls in our body, then the whatever is going inside a body that are responsible for the symptoms of hyponatremia. So if you know that what pathology happens in the body due to low sodium level, you will know the symptoms of it. So basically जो सोडियम होता है ये हमारे ब्रेन पे इफेक्ट करता है, और जो पोटाशियम होता है वो हमारे हार्ट को इफेक्ट करता है. तो बेसिकली सोडियम लेवल की वजह से क्या होता है कि देयर इज द ऑस्मोलैलिटी at increases in the interstitial spaces. ठीक है. And because of which, when the osmolality increases, then the ADH level, that and this basically happens, the sodium level falls, so ADH level increases. So it there, because of osmotic gradient, access of the fluid goes into the cells, that means the brain cells. So brain cells, they swell up. So when the brain cells swell up, they causes the features of all raised ICP, that is headache, nausea, vomiting. They can be stuporous, they can have coma, they can have seizures. So at a sodium level of less than 125, the patient can develop seizures. So these are the symptoms of hyponatremia. In chronic hyponatremia, basically the osmolyte that are present within the cells, they slowly come out of the cells. That betaine, then this creatine, then myoinositol, they all come slowly from out of the cells. So it takes about 48 hours from them to come out. So this causes chronic hyponatremia. So chronic hyponatremia can be asymptomatic, or the patient can have subtle features in the form of gait disturbances, cognitive symptoms, this and falls. Hyponatremia can also cause fractures because of it causes resorption of the calcium from the bones. So it causes this fractures also in these patients due to falls. So these are the symptoms of chronic hyponatremia. So even if the patient had chronic hyponatremia, that's need to be treated, because even in asymptomatic chronic hypertension, we have to give the treatment. So what is the treatment? Treatment are hydration in case of hypovolemic hyponatremia. Then we can give 3% NS to the patient. 3% NS is basically, it contains 513 millimole of the sodium in it. So 3% NS is given slowly. So as to prevent a very, very dreadful complication of treatment of hyponatremia is osmotic demyelination syndrome. Osmotic demyelination syndrome is basically when the sodium level falls in our body, this uh, low sodium level, it can hamper the blood-brain barrier, and the autoimmune triggers that is present, systemic autoimmune triggers, they can go through the blood brain and they can cause the damage to the oligodendrocytes. So oligodendrocytes, they are damaged especially in areas where these like the most important is the pons. This is called a pontine demyelination, because here the reaccumulation of the osmolyte takes very, very slowly. So we cannot predict that how the sodium level will improve in the patient of these chronic hyponatremia. Then extra pontine areas are they can be cerebellum, due to which the patient can have ataxia. They can be basal ganglia like putamen, due to which the patient can have this Parkinsonian symptoms. Then the cortical and subcortical areas can also be affected in these cases. These are called as extra pontine myelinosis. So depending on the site of involvement, the patient will have the symptoms. Then third is we can also give this Vaptans. These are called as tall Vaptans and conivaptan. The tall Vaptan is the oral that we give. This has to be given over a period of 1 to 2 months only. We cannot give beyond 1 to 2 months because it can cause liver damage. Second, the conivaptan is the IV source. It is the IV form of this Vaptans that we give for the treatment of the hyponatremia. So things to remember is that the sodium level at which the neurological features of seizures occur is less than 125. Second, osmotic demyelination syndrome is more commonly seen in patients who are malnourished, who are alcoholic, then who have immunocompromised, those who have liver diseases. So these are all, they are more prone to develop osmotic demyelination syndrome. And most importantly, that we have to give 3% very slowly. The correction rate should be 1 to 2 millimole per hour, or 8 to 10 millimole to be given over 24 hours, and not beyond 18 millimole over 24 hours. Then fourth is the sodium deficit that we have to check before giving this sodium 3% NS is, the formula is 0.6 into body weight into the desired sodium that we want minus the patient's sodium. So this will tell us about the sodium deficit, and accordingly we have to treat. And mind it, within 24 hours we can only correct 8 to 10 millimole of the molecules of the sodium, not beyond that. If you correct beyond that or rapidly, the patient has the chances of developing osmotic demyelination syndrome. Thank you.